Okay, so we'll pick up where we left off. Please know that none of this stuff is on the exam. Yay, which is coming up on Friday. So remember, all you need to do is worry about the stuff I emailed you about. That's what you got to prepare for, okay? Sorry, it's the last day before spring break, but I didn't want to have it after spring break because that would be really terrible of me, because then you'd feel like you have to study during spring break. You're like, screw it, I'm not going to study. I'll study the night before, and that's a disaster. So I took the lesser of two evils, okay? And I know some of you I also have an anatomy exam coming up because I'm listening to you. All right, but at least we don't have a lab quiz in lab this week. All right, and it's not that very long of a lab, and it'd be a cool lab because how many people know, because I got all of you here, how to use a manual blood pressure cuff? Okay, awesome. All right, so for you guys, it'll be practice. For the rest of you, it's not that hard. We don't have the best equipment. Getting into the nursing program, you have to have your own stethoscope, and I forget the maker makes really good stethoscopes. What is it? Littman. They make really good stethoscopes, but they're pricey. They can be up to $300 depending on how nice you want one. Okay, our stethoscopes and blood pressure cuffs are bargain basement. Okay, so but anyway, I digress. It'd be a fun lab. Okay, now let's start where we left off. Cardiovascular system, which everyone seems to love, even when it's anatomy. Heart's fun and important because the big three: hypertension, which really involves cardiovascular system, and then of course cardiovascular disease. All right, so we left off, we were talking about this. It's all review, you've had it before. The ion channels that are found in the heart's pacemaker, which is the SA node. We covered that last time. God, I feel like I can project so much better. Okay, it's going to take me a while. You just have to humor me because this is weird. And then we talked about arrhythmias, which is what you're going to try and detect on the patient when you auscultate their heart rate. It's one of the big things you do when the patient comes in: blood pressure, body temperature, maybe body temperature, yeah, body weight. You'll listen to them, and you're listening for any abnormalities. And I talked to you about all the different heart sounds that you're going to become practiced at learning to pick up as a nursing student. So we talked about treatments for tachycardia, which is a higher than normal heart rate, which brings with it a higher than normal blood pressure. And then bradycardia, let's see if I can turn this around without losing anything, which is a lower than normal heart rate. Okay, so a couple of these are review, but the first one, a treatment, is new. So obviously if someone has and we mean really low, and if you've got an athlete and their resting heart rate is 56 beats per minute, that might be completely normal from them. But anything like lower than 50 they're not going to be functioning. They're probably not going to be even conscious at that point, but there can be some problems that come with that, but not as much as high heart rate, high blood pressure, hypertension. Digitalis can increase the amount of calcium that's available to the heart. And when the heart contracts, because calcium is one of those important ions that it needs along with sodium, it'll contract with more force and it'll eject more blood out of it with each cardiac cycle, all right, with each lub-dub cycle. So digitalis. Now, give me the name of a drug that is a beta-1 adrenergic agonist that makes the heart beat faster. Dobutamine. It was because I said makes the heart beat faster. Is that what? Okay. All right. Dobutamine. All right. That will certainly bring the heart rate up. That'll bring blood pressure up. MAOIA. So a monoamine oxidase inhibitor. It's inhibiting an enzyme that breaks down your monoamine neurotransmitters. So what would be included in those monoamine neurotransmitters that could increase heart rate if you inhibit its enzymatic breakdown? Norepinephrine for sure. And that's going to be in the brain because that's where norepinephrine lives. But what about the rest of your body? Oop, it keeps wanting to do that. And epinephrine, which is in your peripheral nervous system. That is what's affecting your heart rate, the epinephrine. And so that drug can actually increase epinephrine as well as some serotonin. Okay, so notice how I keep reviewing. because by going over things and over things and over things, eventually it sticks. And that's a good way to study is repetition. All right, so, and the clinical app doesn't cover any more than what I've covered here. It actually talks about sodium and calcium channel blockers. But moving ahead, fibrillation. So how many people here are basic life support CPR certified? Okay, good. I got to re-up mine because it's been 2 years and COVID messed it up. But that's good because you never know. I remember many years back, you weren't students here at that time, was that far back. A nursing student was, I guess, getting ready to leave, not leave the parking lot, but leave her car and go to class. And she saw a gentleman, I don't know if it was a student or not, collapse in the parking lot. She ran over. She ascertained by checking pulses that he didn't have pulse. He must have maybe had a heart attack. He had an event. She performed CPR on him. The EMS, campus EMS came because she called him first thing, got CPR, got him back. They got him to the hospital. He lived. Fred Carter, which was the university's president, paid the rest of her nursing tuition. Because, yeah. So the stuff that you're learning, if you haven't got your CPR certification yet, or you have it, that's really important. You never know an event could happen like that. I've talked to nursing faculty that been on vacation and happened to have someone, collapse with a heart attack and had to perform CPR. I've had to do it on animals. All right. So fibrillation, AFib, common enough. My stepdad has it. AFib, atrial fibrillation, is irregular action potential firing in the atrial chambers of the heart. So now that we cover the conduction system, signal starts in the pacemaker, jumps immediately across from the right atrium to the left atrium, and then they contract simultaneously. And then it goes to the base of the right atrium where the AV node is and where it pauses. So we're talking about something wrong in the electrical activity there. Okay. So what's happening is if the atria are fibrillating, which is kind of like this, okay, they're not filling as much as they could with blood because they're not resting enough to fill with blood. That means not as much blood is getting into the ventricles. That means less blood, or if any, are going to go to the lungs and get oxygen, drop off CO2. And then when the blood comes back, the ventricle's not going to fill to pump that blood out. So it's a problem. All right. So lots of things can happen. It's just, let's say it's bad. All right. And it has to be remedied. You have to find out what's going on. So if you look at, this is the normal conduction system, pacemaker, signal jumps from here to here. These two contract simultaneously. Then it pauses here. So remember, when it's contracting here, it's ejecting its blood into the ventricles below. If the atria are doing this, they're not filling and they're probably not contracting hard enough to eject all their blood. So you've got a blood deficit throughout your whole system. All right. So this, I like this. It's all over the place. It's literally fluttering like this. You of course can hear it through a stethoscope. So that's kind of what it would look like. You've got the ventricles are fine, QRS, 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 but everything there where the P wave is supposed to be when the atria contract, there's a lot of noise. There's your P wave, QRST. All right. Obviously that's a mess. So you will see it. It's common enough. You'll see it on a regular basis. Now, a really bad one, not that the other one isn't bad, but ventricular fibrillation is when the ventricles are going like this, okay? A person who's got their ventricles in fibrillation, they are going to go unconscious very quickly, all right? Because those blood vessels coming off it's not the aortic arch. Well, it is the aortic arch. One of them is the common carotid artery that's giving blood to the brain. And then at the base of the ascending aorta, is blood vessels, coronary blood vessels that are going to be feeding the heart. And so if your ventricles are doing this, first thing that's going to happen is your heart is not going to get enough oxygen-rich blood, and then your brain's not going to get enough oxygen-rich blood. And the brain and the heart are both oxygen hogs, and they need a lot of glucose. And if they go a couple cardiac cycles without enough oxygen and glucose in that arterial blood, they're going to stop. All right. So this can be triggered by a heart attack. All right. Or myocardial infarction, I think is what heart attacks actually cause. All right. So the blood is not being pumped adequately. And the big thing is not enough blood to the brain, not enough blood to the heart, and can quickly lead to death. All right, so this BLS CPR certification that you got to take by the American Heart Association, the nursing program, if you get accepted, requires that you are CPR certified. All right, there's a good place in Florence that does it. It's across from the Walmart, big building. And mostly a good sized town will have a place where you can get CPR certified. But someone who is in a heart attack, you have to, so the electrical conduction system is haywire. It's misfiring. And that's why the ventricles are doing this. You got to stop it and reset it with an external defibrillation device, or an AED, external defibrillator device, AED. Question, there's one in this building. Does anyone know where the AED is located in this building? There's one. You've probably walked by a million times. I know where it is because I'm CPR certified, and I always know where all the AED devices are. You know, on the first floor of the, between Leatherman and McNair, next to the candy and soda machines, it's there. So the candy and soda machines here, you turn around, oh, there's the AED device. All right. Good to know as future nurses, because you can do all the CPR in the world, but if you can't reset that pacemaker into a normal sinus rhythm, you're going to lose them. And so that delivers an external shock to reset the pacemaker into a normal rhythm, hopefully. And then the CPR can help bring them back. All right. Okay. So normal sinus rhythm and VFib. So next time you're in a building, pay attention to where the AED devices are, okay? Because that could save a life. And they're really cool. Has anyone ever seen someone use them? Some of you shadow and stuff like that. They have directions. Once you turn the unit on, first of all, you pull it out of its container. It's like a glass container. You open it, you pull it out. It's got a lead attached to the wall. And as soon as that device is pulled out of its closet, let's say, it immediately notifies the campus police and the EMS station that an AED device has been taken out of it. And so they know, okay, and they know where, they know which unit in what building, and then they're gonna converge on the scene. And then you turn the AED device on and it has audible, you can hear them, instructions. Even if you've never used one before, it can talk you through it. It's really cool. All right, okay. Well, obviously that's very dangerous. So one day you have a patient that codes on you, and it's good to be able to know how to do all this stuff. Okay, so all this stuff is very relevant to what you guys are going to be doing on the regular as a nurse and the things you're going to see. I know you're like, oh, it's scary as hell. Of course it's scary as hell. But with training that you're going to receive, the training kicks in over your nerves, okay? And you have to, or else you shouldn't be a nurse. You should fall back on your training, a lot of muscle memory, and you'll be fine. You might be in the back of your brain, I'm freaking out, I'm freaking out, I'm freaking out, but you're going to do the steps you know how to do. It becomes, I don't know, normal. Okay, blood pressure. Now we'll have to go over this week in lab. So I already asked you how many people know how to use a manual blood pressure cuff, and quite a few of you. That's great. In the nursing program, they're not going to expect that you're proficient right off the bat, but they expect after the first semester, I think with, I don't know which class it is, fundamentals or whatever, where you use the laboratory. Has anyone ever been to the second floor of the nursing building where they have that laboratory? It's really nice, okay? And they have, it's a mock-up of a hospital room or rooms where they have the divider sheets on rings. You can actually, it's like a real hospital system. Each station has a blood pressure, it's an automated blood pressure cuff, I believe, and they also have the manual blood pressure cuffs, and you'll practice on each other. So make good friends with each other right now, because you're going to carry those friendships into the nursing program. You're going to be practicing a lot of these things, not CPR, on each other. Okay, so blood pressure is the pressure of arterial blood pressing against the walls of the vessels. All right. So systolic blood pressure is the higher number, and diastolic is the lower, measured in millimeters of mercury. So systolic is when the ventricles contract. Remember I showed you a picture of the heart and I showed you how thick the left ventricle wall is? And that produces the QRS wave in the EKG reading, because it's a huge electrical activity in the heart and the chamber is so thick. And when it contracts, it's pushing blood through all of your arterial system to all your body. And the right ventricle's got some force too. But basically when they contract, you get that systolic blood pressure. The normal range for arterial blood pressure is, and I say systolic, is 80 to 160. So when you work on the next lab report, and it won't be due till later, I'll tell you about it in lab, so you don't have to worry about it during break. Within this range, the body, like, we're okay. Blood pressure between 80 to 160. Your blood pressure fluctuates throughout the day depending on what you're doing. The body does not perceive it as an emergency that needs to be corrected through negative feedback unless it dips below 80 or above 160. All right. All right. Diastolic pressure is when the ventricles are relaxing. That's ventricular diastole. And then that pressure is the lower number. And so you can actually listen to the sound of arterial blood going through arteries. And that's what you're going to be doing this week in lab. So you put a blood pressure cuff. That's why this week in lab, you want something you can roll up over basically the brachium, and the brachial artery is going to be running down in that area, and you're putting the blood pressure cuff over that. You can take blood pressure from other areas. You can take it from the legs even. All right. You just have to have the right size cuff. And what you're listening to, so you pump the cuff up with that little bulb, and you got to turn this little dial here. Righty-tighty closes it off. So when you squeeze the bulb, air goes into the cuff without leaking out. Lefty-loosey releases air from the cuff. So you turn little knob, righty-tighty, you pump the cuff until you get around maybe 160. All right. For young, healthy people whose blood pressure is not likely to be high, you pump it up to around 160, which is about the top of the dial, 12 o'clock position. And that is closing off. It's squeezing the arm. So if you've had your blood pressure measured, you know this. What you're doing is you're occluding or cutting off blood supply to the brachial artery. And then, so once you've got it up to pressure, you lefty-loosey just a little bit, crack it open so the air starts slowly leaking out the cuff. And you've got stethoscope on, and you tuck that stethoscope. I like to, because I'm using it, to put it under the cuff, right over the brachial artery. I've seen some nurses actually have the cuff here, and they'll actually have the stethoscope here. Either way works, but I like it over the brachial artery for the best sound. And so what happens when that cuff is slowly releasing, the artery is going to slowly start to open up. And when it opens up enough that blood is now starting to flow through it, it's going to make an audible sound. When you first hear the sound, you look at the gauge and you record the systolic blood pressure. You keep listening, the sounds get louder, 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 and then they get lower, lower, lower. And eventually they stop. Then you look at the gauge, and that's going to be the diastolic blood pressure. Now, I got bright for the first time. Those sounds you're listening to are called carot cough sounds. That's the sound of blood you're hearing. So I've got a YouTube video, and I apologize if the volume's too loud. In fact, let me turn this around so I don't blast your eardrums off.
Further, with the corticostal readings, they go into phases. So phase 1 through phase 5. So phase 1 is that sharp tapping sound, which is your systolic sound. So that's that first sound that you hear, and you're going to see on the needle. I'm about to show you a live demo on it. It's going to oscillate a little bit.
The needle's going to deflect,
and you're also going to hear it
a little bit
as well.
as
so
blood
I
is
would
going through the
suggest that
artery.
you use a headphone set so that way you can be able to hear everything. Okay, and then in addition to that, phase 2 would be the whoosh. Phase 3 would be the thump, and phase 4 would be a muffled sound.
That really is what it sounds like.
Phase 5 is silent, so that would be your diastolic. So take a listen.
I'm going to turn up way high so you can hear it. Okay, she is releasing pressure. When the needle starts jumping, that's blood going through the artery. So there it is. And look at the needle go. Doop, doop, doop. If you can't hear someone's heart sounds, you can also look at the needle jumping. It's still jumping. It's hard to hear it. And I think around here it stops. And then the needle goes, whoo. All right. So that's what it sounds like.
Thank you so much for watching.
Too loud. Okay. I don't want to. There we go. So now I won't have to go over it with you in lab because you'll have seen it and heard it, but you are going to practice. If even if you know how to do it, practice again. And then the experiment's really, really simple. So this is a little diagram of when the arteries closes and the cuff pressure, they got it at 140. If you have a person who is known high blood pressure, you might have to puff that cuff up to maybe 180 or 200 because their resting blood pressure is already going to be high. It might be 160 over 100. And so you have to be able to get above that, what that would be to hear the heart sounds. So when you release the pressure in the cuff, the artery starts to open, you start to hear the carot cough sounds, you record systolic, it keeps releasing until eventually the cuff is released of all air and the artery is wide open. When the artery is wide open, there's no resistance to it. So you don't hear the sounds anymore. All right. When the sounds disappear, that's going to be the diastolic. So you also don't want to goof around and wait. You want to do this rather quickly because when the cuff is fully inflated, you're cutting off arterial blood supply in the arm. So you don't want to dawdle. But it's not difficult. It just takes practice. Okay. So now we get into some physics and physiology. You'd be amazed at how much the body works by physics. So cardiac output is a real term. It can be measured. It is often measured in patients with cardiovascular problems. You want to see how much blood is the heart ejecting either to the pulmonary trunk or the aorta. So how many mLs are being ejected by the heart every minute? And so it's a very simple formula. You're going to have to know simple formulas in nursing. You're going to be calculating drug dosages. So you're going to be learning simple calculations like this. So cardiac output is mLs, come on, pen, of blood leaving the heart every minute, mLs per minute. It's calculated by the ml of blood with every beat, every lub dub, or every single cardiac cycle. A cardiac cycle, one cycle is a lub dub. All right. So that could be measured. And of course, heart rate is beats per minute. In lab, you're going to be using either palpation of the radial pulse, which is right here, thumb side, or the carotid pulse in your neck, right? Which you probably already know how to do. Okay, average heart rate varies a lot depending on your patient. If they're fit and athletic, that heart rate can vary a lot, can be below 60, and that's completely normal. Stroke volume, all these things will depend on body size. Okay, so if you've got someone who's a large body size, they might have a larger than average stroke volume simply because of body size. But 70 to 80 mLs per cardiac cycle, per lub dub. The average cardiac output, so that's per minute, 5.5 liters. That's a lot. I think some of you bring around things like this, some liter bottles, whatever, and imagine 5.5 liters your heart is ejecting every minute. That's amazing. Okay, and I've got the picture of the heart here where they've basically put it in an enzymatic bath to digest away all the muscle tissue and everything else. And then they injected a colored latex into the vascular system of the heart. You can actually see the heart shape because of all the blood vessels. So what affects cardiac output? Lots of things. So of course, the things that come into its calculation affect it. So heart rate, and we'll talk about the things that affect heart rate. Stroke volume, it's in the formula. Something different is called end diastolic volume. And I like to make it an acronym and call it EDV. Okay. So you know what heart rate is. I just define what stroke volume is. End diastolic volume. Diastole. What's happening during ventricular diastole? The ventricles fill up with blood, hopefully maximally. So that's at the end of ventricular diastole, the ventricles should be maximally filled, and then they're getting ready to contract and eject their blood into the pulmonary trunk or aorta. What determines end diastolic volume is, do the atria fill maximally? And what determines that is venous return to the heart. Venous return to the heart is very important. In anatomy, you learned the veins have valves for one-way flow of blood. The muscles around your veins contract off and on, and that will put pressure against the veins and increase venous return to the heart. People who fly jets in the military, they wear a tight suit on them, and so do astronauts, because if they take a sharp angle upward, gravity, G-forces, want to pull blood away from their head and neck. The blood will want to pool in your veins. The experiment we're doing today is a tiny little study of that. And the tight suits squeeze the veins and increase venous return to the heart and keep blood from wanting to pull down with the force of gravity. In lab, what you're going to do, and please, if anyone has any health concerns, they have what's called orthostatic intolerance, which means they don't tolerate changing body postures very quickly without passing out. And some people might have a heart condition I don't know of. If you do, let me know. Don't participate in the experiment, just take the data. But you're going to lie down flat on a table surface or a bench out in the hallway for about 5 minutes with a blood pressure cuff on, stethoscope in place. And after 5 minutes of laying there, gravity is acting the same on your body from head to toes. So gravity is equal. Okay. Then you're going to measure blood pressure and heart rate and write that down. The patient, you're going to feel it. Patient's going to look like a triage unit in lab. Patient's going to continue to lay there supine to let the brachial artery relax because you just squeezed it with a cuff. Then they're going to stand up and you're going to quickly remeasure heart rate and blood pressure. And what you're going to find in most normal people is that heart rate and blood pressure increase in the first 10 to 20 seconds of standing. That's your body's negative feedback way, the quick fix, the medulla in your aortic arch and carotid artery baroreceptors. When you stand up, gravity is going to start pulling on your blood, especially your carotid arteries. You don't want the blood to pool from there because you pass out. So what the medulla does as soon as you stand up is it stimulates an increase in heart rate, which will increase blood pressure. And it's also, with its vasomotor center, causing all your arteries in your body to vasoconstrict to increase blood pressure. I can't measure that in the lab. You can with stretchy bands that are attached to sensors, but I don't have those stretchy bands. But you can certainly measure heart rate and blood pressure, and you're going to find it goes up. And that's your body's way of compensating for the effect of gravity to keep blood going up to the head so you don't pass out. Most normal people, when they stand up from after lying down, you might see some stars or something, especially if you've been there for a while. But most people don't pass out because of that response, that quick negative feedback response. Okay. Well, that was a bit of a tangent from end diastolic volume, but okay. The other thing that affects cardiac output is the stretching of the ventricles, which is related to end diastolic volume. So I'll go, whoop. All right. If the ventricles fill with more blood, you have a good venous return, lots of blood returns to the heart, the atria fill maximally, that means the ventricles fill maximally and diastole, then they're going to stretch, and the heart itself has stretch receptors. And what will happen is a weird thing about muscles, even skeletal muscles do this. When muscles are stretched, when they contract harder with more force, and your heart does this. So if the ventricles fill a lot and they stretch, when the ventricles contract, they're going to contract really hard. And you get a good cardiac output, a good ejection of blood. And then lastly, oops, I'm going to put it over here because if I do this, it's going to total, come on, let me write. Total peripheral resistance. Okay, or just TPR. Now, imagine, if you will, your blood. If you're dehydrated and the liquid portion of your blood is decreased because you just need some water, all right, your blood is going to become thicker because the water component of your plasma has been reduced, and that blood is going to be thicker. It's going to have more resistance. Imagine you have a tube and a syringe, okay? And in that syringe, you've got corn syrup, right? You did the lab with the egg and the corn syrup. You know it's thick, right? And you try and push that corn syrup through the syringe, through the tube, it's got a lot of resistance to it because there's less water content in that fluid. So that is going to increase resistance, and it's going to make it harder for the heart to pump that blood out. So with more resistance, cardiac output goes down. If you had in that syringe just plain water, there's no resistance. It's plain water. You press the syringe, the water comes squirting out. So with less resistance, the heart doesn't have to work as hard, so its cardiac output goes up. Okay, but there's other things than the water content of your blood that can affect resistance. When your arteries narrow, vasoconstrict, there's more resistance to blood flow there, all right? Versus when you vasodilate, it allows a greater blood flow. Okay, so let's move on and we'll do these one at a time. So heart rate. As heart rate increases cardiac output. And I'm going to call it CO after this. Increases. Makes sense. Your heart is beating faster, more blood's going to come out of the heart with every cardiac cycle. And as heart rate decreases, I'll do this, cardiac output CO goes down. In fact, all those factors I talked about in the previous slide, stroke volume, heart rate, and diastolic volume, and stretching of the heart, there's a direct correlation to what they do to what cardiac output does. So as heart rate goes up, cardiac output goes up. As it goes down, cardiac output goes down. So whatever those first 4 factors do, if they go up, cardiac output goes up. If they go down, cardiac output goes down. The only one that's the odd one out is resistance. Because if resistance goes up, cardiac output goes down. If resistance goes down, cardiac output goes up. So for all the other factors, the arrows go in the same direction, but with resistance, they go in opposite reactions. So what are some things? Obviously, heart rate changes with sympathetic and parasympathetic stimulation. With parasympathetic, epinephrine binds to its beta-1 adrenergic receptor. Heart rate goes up. And if it's acetylcholine binding to its muscarinic cholinergic receptors, it's going to slow down. What are some drugs? Do I have it? Let me see before I write down. Yeah. What are some drugs we've covered that can increase heart rate? Thus, it will increase cardiac output. And go. Dobutamine. Yeah. Isoproterenol. That's a hard one. Okay. And while I'm thinking of it, pure epinephrine will too, because you can administer epinephrine. Okay, that's good. Excellent. Okay, so all those things increase heart rate, it'll increase cardiac output. Now, what are some drugs that will decrease heart rate? Propranolol, because you want to know the drugs for the test that's coming up. Is that a beta-1 specific blocker, or does it block both beta-1 and beta-2 receptors? It's a general. It'll block the beta-1 receptor on the heart, bring heart rate down, but it'll also cause bronchoconstriction. This is not the drug for a patient who has high blood pressure and asthma. That's not the one. What would be the one you'd want to give to someone who has high blood pressure and asthma? Atenolol. Any other drugs? You don't have to know the name, but you can know its class. Sodium channel blocker. Or a calcium channel blocker. And I'm going to add some other things to the list above. And you didn't have to memorize those drug names, but you'll learn it in pharmacology. Which one, the A or the B? MAOI could increase heart rate. A, because A is for anxiety, which epinephrine would give you, or appetite, serotonin. And also digitalis, which I just introduced, so I didn't expect you to remember that. But it increases calcium available to the heart, makes the heart more efficient pump. All right, nice. And see how I stuck some review in there? Huh? All right, I try. Okay. Stroke volume. All right, that's ml of blood with each cardiac cycle. So it's every lubbed up. So real simple. As stroke volume goes up, cardiac output goes up. As stroke volume, I'll just do SV because I don't feel like writing it out again, goes down, cardiac output goes down. Very easy. And the next ones are going to be the same. As it goes up, cardiac output goes up. As it goes down, cardiac output goes down. So I think that's all I have on the slide, just that one relationship. Okay, the next thing is end diastolic volume. So I've got this little pie chart in here, and the numbers aren't perfect, but it's just meant to get a concept across to you. At any point in time, most of your blood resides in your veins because they're stretchy, they're very elastic. And so most people think, oh, most of your blood at any point in time is in your arteries. That's just simply not true. Some of it's in your heart, some of it's in your arteries, some of it's in the pulmonary vessels of your lungs, but most of it's in your vein. So the return of venous blood to the heart, yes. Yes, absolutely. Yep. Sorry. Thank you. You know, funny things happen when you talk and think and write at the same time. Okay, thank you for catching that. So, basically the amount, I'm going to abbreviate amount of blood in the ventricles during diastole. And I'll put here, influenced by venous return. So those things are directly connected to each other because what's in your veins determines how much blood goes back to the heart. So as end diastolic volume increases, I'll make sure it's right this time, cardiac output goes up. As end diastolic volume goes down, cardiac output goes down. Okay, so anything that slows venous return to the heart is going to affect your heart's output just by the physics of it, how much blood is coming back to the heart. You might have seen this. I've seen it enough on TikTok, embarrassing things where people pass out at events. When people are standing still for a very long time, especially if they're not moving, not even twitching a muscle hardly, all right? It actually can slow venous return down. It's actually good to fidget, move your legs around a little bit, use your muscles, squeeze those veins, increase venous return. Because if you're not, venous return can be slowed down and cardiac output goes down, and then your brain gets slightly less flush of blood with a decreased cardiac output, and that's when you're going to pass out. So it's actually very good to fidget because you're increasing venous return because that affects this. Okay, moving on to stretching of the heart, which is related to venous return. The more blood that fills the ventricles, it stretches them. Okay, so stretching this. Oh, I have this diagram here. Oop, went too fast. The right side of the heart and the left side of the heart should be processing equal volumes of blood. There should be a 1-to-1 ratio. You're going to learn all about this as nurses or actually in a hospital system. So what the amount of blood leaving the right ventricle going into the pulmonary trunk to the lungs, that should be an equal amount of blood that's entering the left ventricle when it contracts, pushing it out into your systemic system. There should be a 1-to-1 ratio of that. If not, and it's mismatched, then you're going to have a problem. Let me just say that. I don't want to complicate this more than necessary. But venous return must equal cardiac output. Okay, the stretching of the ventricles. And I like to think of it as the frank stretching Starling law of the heart. It's actually a law of physics. That's why I said your body works on a lot of physics, but you guys don't have to take physics as pre-nursing students. But anyway, as end diastolic volume increases, more blood fills the ventricles in diastole. So another way of saying this, as end diastolic volume increases, ventricles will stretch more. And they're being stretched because with blood. Okay? And when this happens, this stretching increases the strength. I was going to use a more complicated word, but I don't need to. Strength of heart contraction. When I say heart, I'm talking the chambers. Okay, if it's stretched, the ventricles will contract harder, and that will increase your cardiac output. So as end diastolic volume increases and your heart chambers are stretched, cardiac output increases. If there's less blood filling the ventricles, they won't stretch. So as end diastolic volume decreases, cardiac output goes down because it won't contract quite as hard, and that will affect cardiac output. And yeah, you can actually measure all of these things in a clinical setting. Okay, the last one is resistance. So think about the corn syrup versus water analogy. So I added an image, so don't be freaked out, because I wanted to actually have it versus me waving my hands. That is the resistance of blood flow in your arteries. So let me define it first. As TPR increases, now we've got an inverse relationship. Cardiac output goes down. So they've got here blood viscosity with resistance. This is supposed to be a couple of red blood cells and a lot of water. All right. Watery blood has less resistance. It's like pushing water through a long tube. There's not going to be any resistance. This tube, you've got more red blood cells packed in for whatever fluid is there. The blood is thicker and it's going to have more resistance. All right. Another thing that affects resistance is how long is the blood vessel? I don't know if you've ever noticed this. I've been watering things in my garden. I hope it doesn't freeze with the frost we're going to get this week. But anyway, the longer the garden hose is, the lower the volume of water and lower pressure at the end of that. If you've got a short tube, all right, that's going to have less resistance. So they've actually got a tube here that's shorter and that one's longer. This is going to have less resistance. And the longer the tube is, the longer the blood vessel is, the more resistance. And also, if your arteries vasodilate, that's less resistance. If they vasoconstrict, that's more resistance. So as TPR decreases, now it's like more water in your blood. Cardiac output goes up because it's easier to pump blood that is less viscous. All right. Again, all physics, but all these things are things you can measure in the blood. So my last slide after this will have all these factors and the arrows going in the correct directions for them. So basically, all this, and I'm going to double check, arrows are going in the right direction, right direction, right direction, right. Heart contractility means the strength of the contraction, and then this, they're opposite. Now, me talking, waving my arms and all this stuff, you might get it, you might not get it, but this video, if you're on your own time and you click here, is a really good YouTube video explaining all the things that I just talked about. So I'm not going to click on that here because I'm going to move on. Okay, so covered blood pressure, covered all of these things, and I'm looking at the time here, monitoring it. Let's see what's next. Oh, yes, this is important. So what I'm covering next, and I'll get to more of it on Wednesday, the ways that your body regulates blood pressure. Okay. Way back in chapter 1, I gave you an example of negative feedback, page 5 of the wiki text, where I describe it. If blood pressure drops below normal, baroreceptors in the aortic arch and carotid artery sense it. And the medulla is the integrating center, and it has a cardiac center and a vasomotor center. So if blood pressure drops too low, it's got to be fixed. It's got to go up. So your medulla increases your heart rate and causes vasoconstriction of your arteries, and your blood pressure goes up. And if the blood pressure was too high, medulla will do the opposite. Heart rate goes down, arteries open up wide, and your blood pressure drops. Okay, that's a quick fix to blood pressure, but it doesn't last very long. Like I gave you an example of what you're doing in lab today. That fix affects, I think it lasts 10 to 20 seconds, and then it goes away. Long-term fixes to blood pressure problems are going to involve kidneys and hormones. And you're going to need to know these hormones and how they fix blood pressure for nursing. They're going to expect you know this stuff. So I'm not going to get to all of it today, but I will say your kidneys are the most important organ system for regulating your blood pressure. And the hormones I'm going to talk about on Wednesday affect what the kidneys do. Now, in short, your kidneys can help increase blood pressure if they cause more retention of water. So you retain water, more of it goes back into your bloodstream, your urine output goes down because you're not going to pee out body water. If you retain water, your blood volume goes up and your blood pressure goes up. If your kidneys pee out a lot of body water, you're losing body water out through your urine. That makes your blood volume go down. That makes your blood pressure go down. Okay. And then the kidneys themselves are affected by sympathetic and parasympathetic control. But I'm not going to get into that right now. I'm going to leave you with that thought. And then on Wednesday, we're going to get into those 3 things the body does to regulate blood pressure. I'll see some of you in lab.